Good afternoon. Welcome and thanks for joining us for today's HIS Talk webinar, Patient Education Data, a key ingredient for improving quality and patient experience. It's brought to you by Healthwise. I'm Lori from HIS Talk and I'll be moderating. We have two presenters today. First will be Marta Silvia. Marta is the Senior Manager of Quality Improvement and Outcomes Research at Healthwise. Joining Marta will be Vicki Maisonneuve. Vicki is the Director of Nursing Center of Excellence and the Magnet Program at Parkview Health. And with that, I'll turn it over to you, Marta.
Thanks, Lori. Hi, everyone. As mentioned by Lori, my name is Marta Silvia, and I'm the manager of our Quality Improvement and Outcomes Research team at Healthwise. Before we begin, I want to just make sure that you know a little bit about Healthwise. Healthwise has been around since 1975, and our sole focus is health education. Because we're independent and nonprofit, we can produce uncompromising evidence-based content with unmatched rigor in the industry. We pride ourselves on thorough clinical review, in-house experts, and real-world user testing. Backed by behavior change science, our content delivers more than just information. It engages and motivates people to live healthier lives. While our patient education is easy to understand, most things in healthcare are not. And one of those things that's not easy to understand is the data behind it. Healthcare organizations right now are gathering massive amounts of data. And because there's so much data, it can be difficult to know which data is meaningful, let alone how to take action based on what we think it might even mean. Some estimates right now are showing that healthcare data is doubling about every 73 days. And by 2020, experts say that it might exceed 2,314 exabytes. And I have to let you guys know, I didn't even know what an exabyte was before I learned this stat. I actually had to Google it to understand that it's about 2.3 trillion gigabytes, which is a number you might be more familiar with. And because there's so much healthcare data available, less than 0.5% of that data is ever actually even analyzed. On top of the sheer volume of data that's out there right now, data is also scattered across various systems. It's in disparate formats, and that can make it really difficult to analyze or make sense of how the data can even be put together in ways that make sense as well. The average health system actually has providers using about 18 different EMRs when you look at their inpatient settings, outpatient settings, and when you're really looking at all of the affiliated providers that are affiliated with a health system. And in addition to the EMRs, health systems also increasingly have access to other data sources. Those things are things like claim records, pharmacy benefit information, patient experience data, and any other applications that patients might be using. This is just too much data right now, and in order to start to think about what data is important to you, we recommend starting by narrowing your focus. And there can be a few different ways that you can do that. There might be specific conditions that your system is prioritizing. Reasons might be things like opportunities for improvement, or you might have highly specialized staff in a specific area. Your organization might also have strategic initiatives that are important, and these can be good areas to focus on as well. And finally, your program or department might have success criteria that can help you narrow in on what program elements are relevant for you. So any of these reasons can give you a good starting point, but the most important thing is to narrow your focus, or else you can easily be overwhelmed in this sea of data. So today what we're going to talk about is an area of healthcare data that's often overlooked, and that is data associated with patient education. I'd like to introduce you guys to Vicki from Parkview to help us talk about the role of patient education at Parkview. Vicki?
Thank you, Marta. As I said, I am Vicki Maisonneuve. I'm the Director of the Nursing Center of Excellence and the Magnet Program for Parkview Health in Fort Wayne, Indiana. Parkview is a not-for-profit, community-owned healthcare system focused on providing excellent care for every person every day. We have 10 inpatient locations, 160 plus physician practice locations, over 1,000 inpatient beds, 13,000 employees and growing every day, 850 plus providers, and 25 different specialties. And we are a Magnet recognized healthcare system for all of our facilities, as well as the other awards and many others that we have not highlighted. Of this, Parkview Health has always had a passion for innovation. I have worked for Parkview Health for 37 years, 35 of those as a registered nurse, a practicing clinician in the healthcare setting. A belief that patient and consumer education is a significant part of the healthcare journey for our patients is critical to the success and the outcomes for our patients. And that's why this data analytic project was so exciting for me as a nurse and a clinician at Parkview. Education plays an important role at Parkview. One of the things we looked at is that we, being a nonprofit mission dedicated to excellent care for every patient every day, we wanted all of our education to be patient-centered. It needed to be evidence-based, and the tools needed to help people be able to better understand their health. Clinicians being very busy in the workflow that we have, education had to be conveniently accessed through the electronic medical record, no matter where the patient was within the continuum of the healthcare services we provide. It had to be accessed in the clinical workflows in an easy way, and it needed to be consistent everywhere. So no matter where the patient was, they were receiving the same quality evidence-based tools. And it needed to support many accreditations via stroke, trauma, magnet. Depending what it was, that the education had to be available to support those initiatives for our healthcare system. The other big thing we needed to look at was, as we said, it needed to be consistent across the patient journey. So when we looked at online, whether they were in an ambulatory physician office, clinic, healthcare, at home through the bedside and MyChart bedside applications, or population health for our patients that we follow throughout their continuum. It needed to be standard and consistent. We needed to assure that patient education was truly hitting the needs of that patient. We had a strong belief that patient education could reduce readmissions and lead to better outcomes for our patients. So our hypothesis going into this process was that patient education data could be used to better understand the impact of education on the patient experience and other aspects of our operations. And when we think about that one-on-one interaction that we provide to our patients, it truly builds that relationship. And that then ultimately provides a better outcome for our patients, as well as a better overall experience as they move through their healthcare journey. Back to you, Marta.
Thanks, Vicki. So there's two primary areas that we think patient education data are critical in carving out as the most meaningful ways to take action. And those two areas of initiatives are process improvement and patient experience. So first, let's take a look at process improvement. So we know that in order to see the benefits of patient education, health systems actually have to use it. And we also know that there's a wide variability of education used in many educations, and that can be different from department to department, from facility to facility, and even from clinician to clinician in the same hallway. So when you think about process improvement, you want to make sure that you're measuring utilization, and patient education data can help you understand and manage those processes. That management and processes can lead to reduced variability, and that can also identify areas of success and where you can highlight best practices, and where you can also identify areas for improvement or gaps that you can fill. The other area that patient education data is very important for is patient experience. So we also know that measuring the impact of patient education on health outcomes is incredibly difficult. However, there's also evidence that connects patient education with improved patient experience. And while there's a lot of different factors that can contribute to an individual's health, you can use patient education data and patient experience data, therefore, as a proxy to understand these difficult areas that are not captured by health outcomes. Those are things like capturing aspects of patients' understanding of medications and side effects, care coordination, teamwork, and even aspects of patient communication, like helping understand if patients are feeling more understood, respected, and listened to. So today what we're going to do is go through how to use data to drive quality improvement. And we're going to talk about the 4 steps that we've identified you can use through process improvement and patient experience data. So we'll first talk about determining your goals. Then we'll go through how to identify the data metrics that are associated with your goals. Finally, moving into gathering, presenting, and interpreting that data, and then how to actually use that data to inform decisions. So let's start by looking at how you can determine your goals. So what I'm going to do is go through a few examples that relate to patient education. Again, these are just examples, but as I mentioned, these can help you figure out what's strategically important for your system. So the first one is a gold standard in the industry. Most organizations aim to reduce unnecessary readmissions to the hospital and inform educated patients who receive written instructions are readmitted at lower rates. Another goal many organizations share is an aim to improve patient safety. Related pretty specifically to readmissions in many ways, patients who are able to understand and watch for symptoms and side effects are also able to seek care at the appropriate time and reduce further complications. So improving safety is definitely another goal that we see as important here. And finally, another last example that I'll talk about, and so will Vicki further on in the presentation, is improving patient experience. Patient education contributes to high-value interactions with clinicians. It can boost communication with both physicians and nurses that lead to patients being more involved in their care decisions. Educating patients can contribute to these and boost communication as well as perceived experience. All in all, it's important not to overlook the value that patient education data can actually bring to your strategic goals. So Vicki, can you talk about how Parkview identified your goals?
Certainly. Our biggest initiative was truly to begin to look at an overarching strategy to better understand patient education utilization patterns across Parkview Health system. And in doing that, we asked that everyone provide to us basically a spreadsheet of everything they were using. And let me tell you, that was a huge undertaking for a health system, but it was also a huge light bulb of understanding that we were not being consistent in the education tools we were providing to our patients. Being a nurse, we tend to hoard, we tend to keep things that we find valuable when we're providing care to our patients. We found one tool back to 1978 that was no longer evidence-based. So there were many examples of opportunities that we saw as we began really looking at our utilization. The other thing we began to look at is the number of vendors that we had providing different pieces and parts of our educational tools. As we did that, one of our biggest things was looking to implement strong governance through our Peace Committee. This was a massive undertaking to review every patient education tool that we offer within Parkview, and then to limit to one vendor across our health system to assure that consistency that I spoke of earlier. So we have a Peace Committee, Patient Education Advisory Committee, that now reviews every piece of education that comes into Parkview, any custom content that is requested, as well as any homegrown creation. We had to then look to identify a connection between education and patient experience. As I talked about earlier, being a clinician, that relationship that you have with your patient truly drives the patient experience. When you look at numbers, oftentimes as a clinical nurse, it's just a number. But when you are able to connect the dots for the clinical staff to say that number represents that patient's perception of the care we provided, that truly hits home. So if you're able to connect the experience scores and the education you've provided to the why for that clinical nurse, you're going to certainly demonstrate the impact of education on outcomes, specifically for satisfaction in clinical initiatives within the health system or your hospital environment.
Thanks, Vicki. So once you've identified your goals, it's important to choose metrics that will accurately reflect your progress towards those goals. So I'm going to give you another few examples of specific metrics that can be important for patient education related initiatives. So the first example helps you identify utilization patterns and monitor compliance towards standard policies and procedures. As you heard, that was something that was important for Vicki. So if your goal is to optimize workflows for standard distribution, consider measuring the rate of encounters where education is given. This metric allows you to compare how often education is being given, and then it allows you to slice and dice by care setting, department, or location. Another example of an important metric is related to when patient education is given. It's important for patients to be receiving education throughout their admission. Doing so makes education easier to consume. It allows nurses to reinforce those teachings and address different learning styles. And ultimately, it improves patient and clinician communication. We know workflow inefficiencies can contribute to patients receiving all education at the end of their discharge. So if your goal is to improve patient comprehension, considering measuring patient education, the timing, when it's given during this day, compared to patient education that's given all at once at discharge. The last example I'll give today can address the variability in the types of patients you may be seeing. For instance, patients are more likely to have a better experience and improved outcomes if they receive education in their native language. One health system we've worked with had about a quarter of their patient population that were primarily Spanish speakers. When we looked at how often they were providing content in Spanish, however, they were only distributing Spanish content 2% of the time. So if your goal is to improve health outcomes for your patient experience for your Spanish-speaking population, or whatever other language they might be speaking, consider measuring the distribution of Spanish content relative to the percentage of patients who list Spanish as their primary or preferred language. So these are just a few examples that we've identified as valuable to the organizations looking to measure the value of patient education. But it's important to ensure that the metrics you select are actually driving processes. Vicki, can you tell us what metrics Parkview selected?
So as we began looking at this data analytic projects, some of the areas we were most interested in was the encounter by rate of education given. So depending on where the patient encounter occurred, how were we doing? Were we actually giving them the Healthwise or EMR education at that time? What was the department specialty by rate of education given? Was there an impact? Was there more available resources for certain specialties, or was it certainly a piece of workflow that we needed to talk to? What was the average percent top box score by rate of education given? And that was really looking at our HCAP scores over time, comparing scores before and after the activation of our multimedia education at the bedside. And this included TV portals and our tablets that we are now using in all of our inpatient areas. So this was an area that truly was kind of that light bulb moment, that aha moment in truly seeing the impact of education to patient experience.
Great. So now that we've talked about identifying your goals and selecting metrics that drive towards that improvement, let's talk about getting the data together. First off, it's really important to establish cross-functional teams to be a part of the project. Team members may come from different care settings, specialties, or centers of excellence. It's also important to have collaboration across roles in order to make sure you've got the full context and can understand truly what's going on. That's going to typically include clinical representatives or nurses, training staff, maybe education champions, and people like that. Once your team is established, it's time to get the data and combine it from all of the places that it may be stored. That could be the EMR, the patient portal, bedside applications, and patient survey data. So once you have all the data, it's crucial to clean this data and normalize it across your sources. And this may include taking an inventory of all the data sources, developing standard naming conventions, and really just establishing consistency across these sources. Finally, in order to maintain data integrity moving forward, you need to develop a data governance plan and establish baselines or expected values so you can tell if new data doesn't look quite right. So once you have all the data together, you must present it in a way that you can start to make sense of things. So start by putting it in a visual format. We've chosen an interactive dashboard that's easy to share and understand. And this interactive dashboard allows you to slice and dice data so that you can both understand broad trends as well as narrow down to specific things like locations or conditions or anything else that you've included in your dashboard. It's also important to be able to make sure you can share that data with others. So make sure the format allows you to get what you need for newsletters, team huddles, or maybe just regular meetings. And finally, make sure you're able to tailor the view of the data so that for those that you're showing it to. So this allows you to present it in a way that will make sense to your end user. For instance, it may not make sense to show your entire health system's data at one team meeting. So make sure you can do this with the tools that you have available to you. So now that we've kind of talked about some best practices, I'd like to show you an example of a data visualization dashboard that's related to patient education. So this setup allows you to easily analyze different aspects of your data. So there's a lot here. So I'm going to break down each section so you can get a better idea of what we're talking about. Okay, so first off, the section highlighted here is a graph that's actually showing the rate of education for the selected groups over time. The timeline is really important here to show us the changes so that we can see how things are going and changing. And again, I'm seeing the rate of education given. So the top line is the number of encounters, and the bottom line is the number of educational pieces that are being given out over that same time. The next thing I'll show you is this section here that's showing different facilities. And again, you see the rate of education being given by facility. So this is important to be able to compare specific facilities against each other. It also allows you to see relative percentages against absolute encounter. This just arms you with more information to be able to assess your opportunities. Similarly, you may want to compare facilities or department specialties in the same way that's actually shown in this section that's highlighted. And finally, it's useful to see the specific content titles and how often they're being used. This is just an example of one way that you can put the data together in a dashboard, but it has been extremely useful in identifying broad trends as well as areas of opportunity. So now that you have all this data and you've seen an example of it, how do you make sense of it all? Interpretation is critical and context is really key. So first we look at broad utilization trends. Are there workflow barriers that are preventing education use in particular locations or department specialties? Are there any missed opportunities for education distribution, or is there just a lot of variability? Then you can use it to monitor compliance. You can discover where clinicians are maybe using unapproved content if their distribution rates are extremely low. And finally, you can use it to monitor gaps in care. Are there specific opportunities to improve education distribution to patients with certain diagnoses or certain gaps? So Vicki, can you talk about how Parkview was able to make your data actionable?
Certainly. The first thing we did was standardized education across the system with a strict internal governance, as I spoke about earlier. Part of doing that was coordinating our vendors and limiting the vendors that we had providing patient education. And then any vendors or any other type patient education tools, hard copy, video, etc., had to be brought to the PEACE Committee, our Patient Education Advisory Council, for review to assure that it met the standards of Parkview Health for education-based practice, as well as readability, etc., for our patients. We coordinated with the vendors to clean and combine our data from various sources to assure again that what we were providing was consistent. We built data visualization dashboards to filter the information narrowly and broadly so that it was easy to show the why, as I spoke of earlier. And that has been one of the greatest things for me as a clinician, to be able to see either very broadly how we're doing, or also drill it down as far as a specific unit to see, as Marta mentioned, are we providing education? What pieces are we giving? What pieces should we be giving that we're not giving? So it gives us that ability to really drill into areas where maybe our patient experience scores aren't as good as we would like, and be able to see what we're giving, what we're not giving, how we are interacting and building that relationship with our patients. So the next slide is a great example when I talk about the why. As a clinical person, again, numbers and data are not always at the forefront when we're talking about different parts of our practice. But dashboards can be used to see trends, opportunities, and areas of success in the education utilization. As you can see here, this screenshot shows the education rates by department specialty. The data visualization makes it easier for us to see trends and opportunities and the areas of success in our education, the way we have utilized our education across Parkview Health. For example, this visualization compares the rate of education given to the numbers of encounters by a specific department. The bubbles to the right further help to indicate a higher volume of encounters, and the higher the bubble is on the chart, the higher the rate of education given. So this means the green blue bubbles are the departments with the higher rates of education given, where the red and orange bubbles show the departments with lower rates of education. So being a very visual person, that is a great way to look at this type of information. So we can slice and dice to the specific departments across our health system, and then also even drill it down further to see the information that they were actually giving. In this image, you can see we've narrowed by emergency departments. Most have a rate of education given to above 85%. So you could assume or infer that the few below will have the opportunity to improve by utilizing some of the same methods that their peers are using across our health system. Another example of patient education distribution by department specialty would be about 11% used through the EMR for family medicine and 88% by emergency departments. So the difference after review and looking at this process is workflow configuration. Who is ultimately responsible to provide education within a specific office, unit, or workflow within your healthcare system or hospital? In a family practice or family medicine or primary care office, it is often the physician, it could be a nurse, a medical assistant. And this has been a challenge for us due to our staffing models and is a current focus to gain consistency in the education utilization across our primary care physician offices and really to hardwire the workflows similar to what we've been able to do in our emergency departments. So as we began to compare the correlation of average percent top box scores or HCAPs with the rate of our education given, we were able to look at our data analytics with Healthwise, and a good example is this chart, which shows the correlation of patient education provided compared with our average top box scores for Nurse Explain. And this was a system-wide coefficient. So you can filter by the question, location, or department. A 0.67 correlation coefficient is a measure of the relationship between the education we gave our patient and their HCAPS outcomes. A 1 is perfect, above a 0.6 is significant correlation. So you can see there is a strong positive correlation, meaning that we would expect to see moving up or down these two together. When the rate of education given is increasing, HCAP scores should increase or vice versa. So to better understand the connection between care and quality, we have a couple examples from one of our community hospitals and how we can connect our education to communication and patient experience. The first one, and how we compare our HCAP scores before and after the activation of bedside tablets for multimedia education at one of our community hospitals. What is significant to recognize here is the bedside tablets were only used for education content, no other entertainment, music, anything else, just education. So when we looked at our scores, the light green is our before activation, the dark green is after activation of the bedside multimedia tablets, meaning we could do hard copy through the tablet, readable, or we could show videos. The first question, how often did doctors explain things in a way you could understand, went from 72.2 to 88% after the utilization of the tablet. The second question, how often did nurses explain things in an understandable way? 74.5% to 90.5%, and that is very significant, both of those. And when you think about those two questions, truly speak to communication and building the relationship with our patients, that one-on-one interaction to truly show them that you care, which is what patient experience truly is about. And then the last one, how often did staff explain what new medications are for? 73.8 to 86.9%. And how many of you have that medication side effect question that drags you down? This is a great opportunity to take a step back and look at how can your education that you're providing truly impact that medication side effect, and then ultimately the outcomes for your patients. So Marta, back to you.
Thanks, Vicki. Congratulations on those spectacular results. It's really great to see those things. So far, we've talked about how to really narrow your focus and identify your goals, and moved into selecting metrics to help drive you towards those goals, and then understanding how to put everything together to gather, present, and share that information. So finally, what we want to wrap up with today is how to actually use all this data to inform your business decisions. So Vicki, can you talk about how Parkview has been able to share these results or progress with your key stakeholders?
Certainly. The biggest thing we did was we provided the data visibility to our Patient Education Governance Committee and our senior leadership. We presented through board quality, different physician leadership groups across our health system, multiple nursing shared governance teams. As a magnet organization, it is very important that our nurses can connect patient outcome to the why for the patient. We were able to make it easy and understandable through the use of data analytics and showing these very visible graphs and charts and explaining it and connecting the dots again to that patient why. We were able to show clinicians a correlation of patient education distribution with the patient experience. And that ultimately, anytime you can connect to the why for a clinical person, it creates a stronger buy-in and utilization of whatever tool or process that you are promoting. And you must continually track and report changes over time. If you recognize that there is a decreased utilization of education, be it through the electronic medical record or a bedside tool, you need to drill into that and see, is it truly we're not activating tablets, we're not providing it, or is it truly that there is an education need, a lack of understanding on how to use the process? We have seen both of those as we've moved forward, and we've had to go back and do re-education, work on teach-back methods. So it allows you to broaden your visualization outside of data, but truly look at your overall processes for patient education across the system.
Great. So once you've shared those results and specifically your progress, it's really important to identify those next step training opportunities that you just mentioned. Vicki, can you talk about how Parkview identified your training opportunities and where you went from there?
Certainly, some of what I just spoke of, but we determined where the training was needed based on data and why it mattered. One of the things we do because of our magnet accreditation, and as well as just wanting to know the information, is we do an annual RN assessment for educational needs. One of the big things that came back this year was teach back, the Healthwise process, Epic quick tips, and how to basically do patient education through our electronic media. So we have created a teach back competency that will be a requirement for all RNs moving forward this next year. So when you think about that, you're basically meeting the needs of your nurses to help them better meet the needs of the education for their patients. And that's truly why we're here. We also plan to continue to focus on patient education utilization and our workflow at all levels of care. How do we move patient education into all aspects of the care of our patients, no matter where they are throughout the enterprise of Parkview Health? And then really focusing in and helping to show our clinicians that data helps monitor progress, both with training and patient outcomes. So the more that we can watch our data and look at it and understand it and be able to provide it in understandable ways, it truly does help the end user be better able to understand why what they do every day is important to the patient.
Excellent. So finally, let's wrap up with how you can actually use this data to plan your quality improvement projects. Those might be related to improving patient experience or monitoring compliance with accreditation requirements, or really just standard education use. And finally, how do we actually optimize this information to help you with your appropriate interventions? Vicki, can you talk about how you're using this data to strategically plan for quality improvement projects?
First off, I think having the support of senior leadership has been imperative for this project. Having that patient education and patient experience and that overarching look at how we are using education is part of our strategic plan for Parkview Health. In doing that, it brings it to the forefront of everyone. It is so important, no matter where you are within the hierarchy of care of our patients, that you truly understand the benefit and how patient education affects our outcomes. we need to look at the results from our multimedia education activation at all community hospitals. And then now we have now moved to activating bedside tablets at every inpatient bed within Parkview Health. And we are currently evaluating the use of tablets in an outpatient wound clinic to help push the education to the patient. They get the tablet when they arrive, and as they're waiting for their appointment, they are able to watch and read some information that then will be discussed with them during their treatment that is coming up. So we're looking to see in the ambulatory setting, is this another way that we can both utilize time as well as improve the patient experience, both for wait time and preparing them to know what questions to ask when they get into their treatment with their physician. So again, it all comes down to communication, both within the care team, as well as the communication and the relationship we have with our patients, and hopefully affecting their experience and outcomes moving forward.
Great. So how can your organization get started? So I just want to wrap up by reviewing really where you can start using patient education data to inform your organizational quality or process improvement goals. First, start with determining your goals and really narrowing your focus to identify what data you should be able to pull in. Then identify your specific data metrics that can help you actually understand and make progress towards those specific goals. Once you've identified data metrics, it's important to gather data from all of the important sources so that you can clean it, present it, and interpret it with context for your health system. And finally, using that data and that interpretation to inform decisions like strategic planning for quality improvement projects and identifying training opportunities. So that wraps up what we've got to share with you. Lori, I'll close it and send it back to you.
Thank you, Marta. Now we'd like to take a little time for questions from the audience. As a reminder, please use the questions section of the GoToWebinar panel to submit your questions to the speakers. The first question, Sherry would like to know if you can explain what you mean by rate of education given.
Absolutely. So when we talk about the rate of education given, what we look at from a numerator and denominator standpoint are a denominator is your number of encounters that are, we'll say, relevant encounters. So for your health system, that might be office visits. If you're an inpatient facility, it might be admissions. We found a standardized way to understand what your number of appropriate encounters would be. And then your numerator is the unique number of those encounters where any piece of education was actually provided. So when you look at the rate, the numerator is the number of encounters where education was provided over the total number of eligible encounters for your health system. And that might be a little bit different. So when you look at your different care settings, it's important to understand what an encounter might be. So encounters might actually be different for different parts of your health system. So it's important to just kind of understand what those differences are so that you can actually normalize on the different meetings when you look at a 30,000 foot level view like we showed you earlier, so that it all kind of makes sense together.
Okay, Christina is enthusiastic. She writes, I love the data with exclamation points. How can I access the data, especially the number of education pieces given from Healthwise?
That's a fantastic question. If you're a Healthwise customer, Healthwise actually does have some tools where we can help you access that information. It's obviously going to be different based on the different EMR that your health system might be using. And we do have recommended queries for all of the different EMRs that we can help you with. So if you are a Healthwise customer, I would say reach out to your account manager and we can help you analyze that, because again, it is going to be different based on your health system and the EMR you're using and the specific solution that you might have licensed from us.
Anwar would like to know, how did you identify the primary specialty for patients needing care from multiple specialties during the course of the hospital stay?
Ooh, that is a great question. I'd have to validate with our data analytics folks that actually did it, but I believe what we did is we actually looked at the primary specialty that was associated with the encounter. And in an
Right.
admission situation, I believe we actually looked at what that was when the patient was discharged. That's a great follow-up question that I can confirm that's how we did it. So certainly we can find a way of getting that information to you. In the outpatient setting, it's obviously a little bit easier, but I'll validate the inpatient setting for you and we'll find a way to get that answer to you.
Do you differentiate between counseling and education?
Ah, that's a good question. I don't know, Vicki, if you want to talk about how that plays out at Parkview, but in this specific scenario, we were looking at when education, written or multimedia education, was actually provided during an encounter. So in this scenario, if counseling was done and they provided a piece of written or multimedia education, that's what we looked at. However, Vicki, I don't know if you want to talk a little bit about how Parkview distinguishes those and how that relates to the data here.
Yeah, we, as we went through our data governance to really look at the education we're providing, we kind of put it in 3 buckets. We put it in patient information, consents, HIPAA, all those pieces, marketing tools, and then true patient education, patient instruction, those pieces that truly impact a diagnosis, medication, or outcome. So when we look at the data analytics, we're looking specific on, as Marta said, an encounter. If the patient is in ED, they came in, what education did we provide them at that time? And then how do those metrics reflect? So I think you could drill it down in different ways, but we were looking at it truly from an education, patient instruction, or multimedia education that we provided the patient through the EMR, or in this case, the Healthwise knowledge base, through video or written documentation, written education tools.
And Vicki, if I could just expand on that one a little bit, I think it's a really great question and a really great distinction of counseling versus education. However, I think one of the things that hopefully we saw when we looked at the data is that if you're providing counseling, when you provide a piece of written or multimedia education in conjunction with that counseling, if it's appropriate, you actually see much better communication between the clinicians, and that's both the nurses and the physicians. And that's actually what our data showed, is that a piece of actual material can really enhance that communication between the patient and the clinicians to provide a high value interaction. And that's why it is really important to make that distinguishment and understand that providing that written piece is actually critical to making improvements.
And that translates to that patient experience and that relationship that we've talked about.
Can you talk a little bit about how you actually capture the data?
Sure. So the way that this is happening now is most of the data that's related to the encounter and the patient survey data, or the patient experience data. I'll talk first about the encounter data. The encounter data is documented in the course of day-to-day clinical workflow. So that's something that your clinicians are documenting, when an admission happens, an encounter is created, and then all of the workflow steps that actually get all of that data documented. The patient education is documented when the clinician either prints or sends a video to a tablet. Those are automated data capture just throughout the course of the workflows. The patient experience data is actually captured through a survey vendor, and that is actually the HCAPs data, and there's certainly multiple survey vendors out there, but that survey data is captured by the survey vendor themselves, and then we were able to take a look at that data in conjunction with the data that's documented in the day-to-day workflow by the clinicians.
Diana would like to know what outcomes other than HCAPS scores have you have been of interest to your health system and why?
That's a great question. So another area that we've been looking at, aside from patient experience, is actually patient safety. This is what we're currently looking at. And specifically, there are two areas within patient safety that we're really focused on, and that's infection prevention complications and anticoagulation therapy. So when we look at infection prevention, there are specific elements that we know are really important for educating patients on the symptoms to watch for after getting things like PICC lines or getting catheters inserted and things like that. So we know that we're looking at the relevant complications that can come about if patients are not educated properly on symptoms to watch for. And the other area is actually anticoagulation therapy. So anticoagulation therapy, as you all know, is very complicated, and it's really imperative that patients understand the importance of adhering to their treatment guidelines. So whether that's actually taking the medication that they're supposed to be or following up on their lab procedures, things like that. So there's actually a lot of education involved in the anticoagulation therapy. So that's been another area of interest for us. Vicki, I don't know if there's anything else specifically that you want to talk about from Parkview as well.
Yeah, another big area for us is readmissions in our cardiac population. We have seen a huge impact of education on our congestive heart readmission rates, as well as a lot of work we are beginning to do with our stroke and stroke accreditation for our stroke outcomes. And just are beginning down the road with our diabetic management and glycemic control. Doing some work with that and truly looking at cross-referencing all of our Healthwise tools to truly look at creating that curriculum per se for our patients as they move through the journey of learning how to manage diabetic management, as well as how to manage their overall health care depending on the diagnosis. So we're really just beginning to see all the different ways we can use this information and how we're using our education, and then trying to learn how to connect it. And being part of a magnet hospital or system, there are so many opportunities to truly look at our patient outcomes as part of our magnet standards. And so how we can look at outcomes for teach-back and the improvement of patient outcomes in certain diagnoses have been and are continuing through nursing research to be a really, I guess, a really great opportunity for us as a healthcare system.
How did you handle internally developed content or content from other organizations such as the American Heart Association?
So that goes back to our governance. As I said at the very beginning, we ask every unit, every area within Parkview Health system to provide on a spreadsheet the different types of education they were using. Was it hard copy, Parkview grown? Was it used from a vendor like American Heart, the CDC? Were they using videos? Were they using things from Dr. Google? You know, what were they using? So that was our first thing, and that was huge, as you can imagine, in a healthcare system. All of these spreadsheets coming in, and it really allowed us to take a look at, say, okay, what are we giving our patients? And very quickly see that we needed to have consistency. So that was the first step. The second step was, at that point, we began to look at what is the difference between internally grown, American Heart, or the true experts in evidence-based practice, and then other tools that were available, like third-party vendors, Healthwise, whoever it was. So at that point, we moved toward a steering committee to look at multiple vendors to provide one true source of education for our health system. We went through multiple steps, multiple reviews, multiple on-sites for different vendors, and we selected Healthwise. So that was the first part. The second part was, at that point, we took all of the homegrown tools that we were using, and we sent back to the people involved and said, we need you to take your homegrown tools now and go into Healthwise and see, can the Healthwise tools that are attached to our EMR, which means they're going to flow into our medical record, can we substitute those now and we get rid of everything else? Because Healthwise was now going to be our main source of truth for education. So at that point, we got rid of thousands of pieces of homegrown education. We still have some. We have branded those for your health. So if we get a piece of education that is homegrown, that isn't branded, that says that it probably hasn't gone through our governance process, and it has to go through. We have a stop at our marketing and our digital media people that they create nothing without it going through piece. We have an online SharePoint site where they submit their reviews. It has to have been vetted through all of our healthcare hospitals and the areas involved. So it is very strict now how they get to that place. When it comes to American Heart, CDC, anything that is the most current, they also have those on their spreadsheet if they use them, because certainly they are the experts. Much of what we create or use and what Healthwise has in some instances comes from those sources. So we have allowed them in those situations to use it if it benefits over and above the Healthwise tool. But they still have to vet them. They still have to report them on an annual review to the peace committee to say we are using this, and it has been verified it is the most recent and up-to-date tool that the American Heart, the CDC, or whoever is using. And as those tools are integrated into Healthwise content, we are then moving away from them. And we've done that in some areas, but certainly there is value to certain tools, certain electronic media, multimedia tools that are available through American Heart. A good example is a blood pressure tool they have. It's very visual, very colorful, very descriptive. It doesn't fit very well in a black and white EMR or in an EMR where pictures aren't as strong. So we vet them, but we assure that they are evidence, they're the most up to date, and then how do they fit into the overarching process for Parkview.
Yeah, and I want to expand a little bit on how that actually works with the data visualization as well. So one of the things that is included in the data visualization that we showed you is it's actually a filter that you couldn't see on that main dashboard, but it is available in other areas of our data visualization, is where what the source is. So if there is custom content that has been integrated into the EHR, we can actually look at the source to see how often Healthwise content is being used versus other sources. It's also one of those things where if it's not actually used within the EHR, that's context that's really important. So maybe it's not fair to judge a certain department against the generalizable whole because they're using content from the CDC or the American Heart Association that's not integrated into the EHR. And that's context that's important to know when you're looking at that rate of education that we talked about. So kind of to sum up on the data visualization, we do incorporate other sources that patient or that the clinicians might be using if it's within the EHR, and that's just context that you might have to know about your health systems for specific department specialties.
And we are just starting in the custom content management side. So some of our homegrown tools that we've created will be moving into the EMR because of the ability to create our own custom content if it is outside or it's a different specialty than Healthwise would offer, or to adjunct and support something they offer, and we want to put a little more of a spin for Parkview on something. We now are getting ready to move into that journey because we are just about not even 2 years out from our start with Healthwise. So have accomplished a lot with this project, and it has been a great relationship to truly build and utilize innovative strategies to provide the best education to our patients.
This is a multi-part question. If videos are sent through a patient portal, will this count for quality metrics if the patient watches it at a different time? For example, when addressing BMI in pediatric patients, can videos be sent to them regarding nutrition and exercise? Do these typically meet criteria for quality measures? What if the patient does not watch them?
That is a fantastic question. Vicki, I'm not sure if that's something that you've looked at with your quality department. Do you know?
So probably more with our heart at this point, congestive heart, and some of those, because there is a time, the interaction, the amount of time that a patient needs to interact with certain educational tools. Currently, those are more tracked internally within the department, within the medical record. Ultimately, I would like to see that as certainly a goal moving forward in some of the work we're doing with Healthwise and the analytics to see that patient, their ability to interact with. And I know there is some work being done on that currently where we can actually visualize if we push education through MyChart to our patient, because we are an Epic user. I'm not sure Cerner and the other ones how that works, but if we push that information, that the goal is that we would then be able to see, has the patient truly interacted with it, have they visualized, viewed, or seen it. And there is some work being done in the background on that, but at this point it is still in its very early stages. So I think there's lots more to come on that down the road as a possible opportunity on how we can better see that pre and post type information. But today, if you push something through MyChart, certainly on the ambulatory side, prior to a patient coming in, you then have the patient have the ability to see it before, visualize it, and then ask those questions or talk to when they come in for their pre-admission testing or their physician discussion prior to a procedure. So there are ways to do it today where you would then document their response to that teaching when they actually come into the setting where you pushed it from initially prior to seeing them, and then see them, you would have the ability to interact with them and document whether or not they did truly interact with the education you provided prior to the visit.
How large is your PEAC group? How many sites or how large is the area that Parkview serves? And how do you manage review of all of that content?
So we meet monthly. It is an interprofessional team. So we have members from respiratory, dietary, nursing, the physician. We have physician oversight. We have a steering committee over piece. So we have representation from therapy. Multiple team members are part of that. So we have about 18 to 20 members, even including our diversity director for the health system. So about 20 members. They are interprofessional. They are from across the health system. And we have 10 hospitals, and like I said at the beginning slide, 10 hospitals, about 850 providers, 150 clinical, clinics and offices. I have to look at my list here, but we are about 13,000 employees at this point, and growing. So we are a regional trauma center. We're a stroke accredited program, Cancer Institute, Heart Institute. So we have a broad, and orthopedics. So we have a broad coverage. So it is a massive undertaking. The beginning of setting up our peace committee was huge. It took multiple, about 12 months prior to getting Healthwise, where we really were walking this journey. And that included multiple sub-teams that were looking at electronic media, written media, homegrown, what are we using? So there was a multi-step process to get us to the peace committee with our governance. So about 20 people, we meet monthly for about 2 hours. Annually, every area within the health system must review their spreadsheet and do updates on whether or not the information is still being used. It is reviewed. And is it reviewed for the most current information? I provide every quarter a peace newsletter that goes out to the entire health system that talks about any new patient education tools within Healthwise, any new processes within Parkview, like our custom content manager, and how they can request to sit down with the peace committee to say, this is why we need this custom tool, and help them in that development process. So it is an undertaking, but we feel it is a very important undertaking to assure that we're providing the best consistent education to our patients. So literally at this point, it's every month, about 2 hours a month that our team comes together. We have everything through our SharePoint site where anybody that requests new information, they go through an electronic process. If it is a request for Healthwise, I vet that through our team, and then it is forwarded on to Healthwise to see if it's something they will be adding to their content moving forward. If not, then we bring it back to our team and look at it from custom content, and that will be our next phase because we're just moving into that process. So at this point, it's not astronomically time consuming. The first year it was a big undertaking as we move forward, but we've been able to automate a lot of it now. We build out SharePoint sites, and we have put the accountability to assure that what people are using is accurate and evidence-based. And we track them and we make sure that that is occurring. So it has really been I think a journey, but a journey that everyone has supported. And having senior leadership heavily involved in the process and the selection committee for our education vendors and the process for peace has been a wonderful adjunct to this process.
Thank you. That's going to have to be our last question since we're at the top of the hour. Thank you, everyone, for joining us today, and thank you to Marta and Vicki for a great presentation. We look forward to seeing you at our next HIS Talk webinar. Enjoy the rest of your day.